All right, hello and welcome to the WPS webinar on Skilled Nursing Facility Minimum Data Set, or MDS, Section GG Issues and Findings. My name is Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education team. And I'm joined today by Rachel and Jennifer, who are going to be helping with the question and answer portion of today's call, as well as we have representation from medical review should we need something from them as well. As caregivers, I think we can all agree that when Section G and Section GG were combined, that Section GG is now a true interdisciplinary assessment, and therefore really a better indicator of the beneficiary's actual level of independence and their need for nursing and therapy care, as compared to the old Section G. Today, we are going to discuss Section GG and some of the issues and findings that our medical review department is finding that often result in a claim being recoded to a different HIPS code. This on your screen is our disclaimer slide. We have to present our disclaimer at every one of our educational events. And in a nutshell, our disclaimer said we prepared this information today using the rules as they are today. So if Medicare rules, regulations, or laws change tomorrow, it's your responsibility as a provider to make sure you're following those rules as they are for the date of service. We will provide responses to questions based on the facts given and the rules as they are today. So the Medicare rules will always be the final determination for coverage. Now, CMS prohibits you from recording this presentation or taking screenshots for any profit-making purposes. Since we don't know why you would be recording, we ask that you please do not do that or stop that if you're doing it at this time. But we are recording it for you, and we will be placing a copy of that onto our webinar page. I think one of my co-hosts might not be on mute, so if you guys can check your settings, that would be great. All right. Sorry for that brief interruption. Let's go ahead and move on. The next slide is acronyms. So this is a whole set of acronyms that I may or may not use in this presentation, but they're all skilled nursing facility related. So if I say an acronym and you don't know what it is, you can always just refer back to this page. My objective for today is that you learn about the identified issues in Section GG of the MDS that can lead to review findings and your skilled nursing facility claims being recoded into a different PDPM payment rate. I hope to achieve this today by reviewing the Medicare drivers of payment for Section GG. I'm going to highlight the importance of keeping the assessment timing accurate for this section and discuss why the MDS information and documentation must match. We're also going to look at some live documentation examples that can lead to possible recoding of claims. Now, as we move on, if you're following along with the slide deck, we're on the slide that's titled Section GG. Section GG includes items about functional abilities and goals on the MDS. So it includes items focused on prior function, admission and discharge performance, discharge goals, performance throughout a resident stay, mobility devices, and range of motion, to name a few. Functional status is assessed based on the need for assistance when performing self-care and mobility activities. It is now a truer interdisciplinary assessment of a beneficiary, which really is a better indicator of the beneficiary's actual level of independence and their need for nursing and therapy care. So because Section GG plays such a vital role in reimbursement under PDPM, accuracy is really critical. So understanding how Section GG impacts the RUG scores and CMIs, the per diem rates and their overall reimbursement is essential with effective management of PDPM. So providers should focus on how to accurately code Section GG to receive the most appropriate reimbursement based on your resident or beneficiary's actual characteristics. So let's talk a bit, why was Section G removed? As I mentioned a little bit ago, Section GG is now a truer interdisciplinary assessment and really therefore a better indicator of the resident's actual level of independence and need for nursing and therapy care. So the changes to Section G and GG were to make things less complex and to really eliminate the number and complexity of RUG scores. So one thing that was ultimately removed was cognition as a factor for PT and OT RUG scores. Section GG scoring then more accurately aligns with costs, regardless of cognition of the patient. So this simplified and reduced PT and OT RUG scores. For nursing, Section GG allows for fewer categories due to really insignificant variability in costs that were associated with similar ADL scores. So the shift of utilizing Section GG instead of Section G for determining the PDPM per diem rate for PT, OT, and nursing really streamlines the number of possible RUG scores, and it also advances the prospective payment decision precision. That was a lot of P's all at one time. So let's look at some examples. On your screen, in your slide deck, we've provided a link to the Briggs Sample MDS. I like to use this sample in training because they have highlighted the areas with Medicare indications, which really makes it easy, especially in training, to see what areas affect Medicare. And I'm going to use the link on the slide and go out and show you this sample. Now remember, this is just a sample and marked as such. I'm not promoting it. I have no vested interest in the company, etc. I just like the way they have included the Medicare indicators. So let me bring this up. All right. And Rachel, can you verify that you are seeing the sample MDS?
Yes, I am.
All right, perfect. Thank you. Okay, so starting on the first page, you're going to notice at the top of this sample, there's some green indicators. The green money bag, I like to call it, so this one that's next to the PDPM, those are sections that affect PDPM payment. The general green and the green hexagon indicate SNF quality reporting program measures. I'm going to scroll down to Section GG, so bear with me and look away if that makes you a little nauseous as I scroll quickly. And we're going to land here at the beginning of Section GG. So remember, Section GG is a big one. And for today's purpose, we're going to focus on those drivers in this section. So as I mentioned before, section GG is functional abilities and goals. And it now includes the information from the former G category. The issues that are being seen in reviews are in the drivers for this section, specifically the information that must be entered and documented within the first 3 days of the SNF admission. Now I'm going to scroll down to GG0130, which starts with the self-care. Again, down here, you're going to see those money bags in this self-care area, which means these areas drive payment indicators, which also means that we're going to pay very close attention in medical review to ensure how you mark these sections on your MDS is an accurate reflection of what's in the documentation. So that means we're going to specifically be focusing on self-care assessment and the resident's level of performance with those associated codes. And again, look at the documentation on admission and within the first 3 days in the SNF. Again, the money bags items in column 1 on admission here are eating, oral hygiene, and toileting hygiene. So these admission items and the mobility continue on the next page, which I'm going to scroll down and show you. So the next page we can see in the admission performance, you have the testing of sit to lying, lying to sitting on the side of the bed, sit to stand, chair to bed to chair, bed to chair transfer, toilet transfer, the walk 50 foot and walk 100 foot if they're able to walk the 10 foot. So then you can see as you scroll down, there are other indicators that are also green and indicators of these are important things for Medicare to have as well. So not everything has to be done or is reflected on your Medicare payment, but these that specifically contain the money bags, these are the big drivers. So anytime you go through your MDS assessment, whether you're in a different section or not, you can see those things are the things that we're going to specifically be digging through your documentation and looking for and making sure you code it correctly in your MDS so we know that the payment amount that you're requesting is correct. All right, so a few things about this. Upon review of this section, we find that we're often missing or cannot find some of the information in the documentation. Another issue is that often we find the information and it's located in the overall interdisciplinary team notes, which I'll now refer to as IDT notes. So in their initial assessment, or sometimes they're in the initial therapy assessment. And sometimes what is said in the therapy assessment and what is said in the overall IDT assessment are not the same. So then we have to figure out, did they both occur within the first 3 days and which one is right? So that sometimes leads to information, you know, that's documented multiple times, but reported differently, which is, again, another issue. So we don't know which information about the patient is correct. The patient assessment may say something different than the nursing assessment or the IDT assessment. So we look at any additional documentation to see if we can determine which is correct. All of this result in an error and the section being recoded. We did get some pre-submitted questions that asked about this very type of scenario. and what providers should do if the interdisciplinary team or the IDT determines usual function is different than what's documented somewhere else in the notes. And really, this is a facility issue. The facility needs to work it out with all departments and determine the actual functional status of the patient within those first 3 days and what's going to be marked and used on the MDS. If we see that the interdisciplinary team has completed an overall assessment, we're generally going to look at that information first. But know that conflicting information in your documentation could lead to recoding of your claim. So keep that in mind. We are looking for the documentation to support this section within the first 3 days of the SNF admission. So if other documentation is after that time frame, we'll use whatever documentation is within that time frame. So again, note that. So here's an example. If the MDS is marked that a patient is completely dependent with sit to lying, but the nursing records indicate that they are supervision only, we may change that MDS, and generally that may change the HIPS code, especially, if it's something in this section. So again, we're going to be going through and looking at the information to support these levels of performance in your documentation. And if that documentation is different, it may result in a change of the MDS, which usually ultimately affects the payment. So at this time, I want to bring up some live documentation. So if you're following along in the slide deck, we're on the page that says moving ahead, documentation review. All right, so let me bring a few things up. All right, now Rachel, I'm going to verify with you. Can you see these examples on your screen?
Yes, I can.
Perfect, thank you. Okay, so as we move on, I have an example, and this is the first patient we want to talk about. And this is section G of their MDS and how they coded it. Now, the qualifying hospital stay for this patient was November 9th, 2023 through the 11/13 of 2023, and they came to the skilled nursing facility on 11/23. Their ARD date was set on 11/30. So the PT and OT evaluations of this patient were also done on the day of admission. So a few things that I'm going to show you. I'm going to scroll down to the documentation that we were able to use that was done within the first 3 days of admission. And then we'll look over here at how it was actually coded by the facility. So if we go back and we think about those drivers that were on that list, we are looking for eating, hygiene, toileting hygiene. So since this was before January 1st, I did use the coding, which is the same on this side of the screen, that was in effect at that time. And based on what they say, their eating is setup or cleanup assistance. So you can see that would be a 5. Oral hygiene, setup or cleanup, which would be a 5 as well. And then toileting was partial moderate, which would code as a 3. As we scroll down on this patient, We see that the other indicators are sit to lying, which is partial moderate. So that would be scored a 3. Lying sitting on side of the bed was partial, which would be a 3. Sit stand was a 3. Chair bed to chair transfer is a 3. Toilet transfer is a 3. And then walking 10 feet, not attempted due to medical or safety concerns. So that would be an 88. And then if you score an 88, you don't have to do the additional 2 on the transfer. So let me scroll back up. Here is how categories should have been coded. Here is what was coded by the facility and locked into the repository. So eating was a 5, oral hygiene, they scored as a 4, living was a 3, and then we get the mobility, so with 3, 3, 3, 3, 3, as they had indicated. But then down here where it was walk 10 foot, this should have been coded as an 88, and these should have been skipped because they assessed the patient as rolling. They were able to wheel 50 foot, but this actually asks about the ability to walk. So this MDS would have been recoded and saved, and whatever classification comes out as on medical, after medical review and after all these things were changed, that's what ultimately we are going to pay the facility at. A lot of times it results in a lesser payment. Now, it could result in an increased payment, but a lot of times it results in a lesser payment. So that is just one example. Patient 2, same types of things. So again, I've given you the coding, and I know this is probably just a little bit small, but again, this was before the beginning of this year. So the qualifying hospital stay was 9/23 to 9/27, and they were admitted to the SNF on 9/27 with an ARD date of 10/19. The PT evaluation was done on 9/27, and the OT evaluation was done on 9/28. So the information that we have found from their assessment report, and this is their interdisciplinary report that was completed within the 3 days, is down here. So we have eating as supervision. We have oral hygiene as partial moderate. So we should have been at a 4, and then a 3. And then toileting hygiene, 1 as dependent, and they've coded that as a 2. And so then when we scroll down to the other indicators, your sit to lying was partial to moderate. And let me keep this up so we can see that. All right. Partial moderate, so we're looking at a 3. Lying to sitting was partial moderate, which would be a 3 again. Sit stand was dependent, so we've got 1, 1, 1 on toilet transfer, and then walking 10 feet, partial moderate, those go back to 3s. So then what is coded on here is all dependent. So then again, as an example, we have to recode this on our end, and whatever hits out based on the new coding, of the PDPM Section G and any other sections that we have to recode, that's what the facility will get paid at. All right. So let me minimize those. All right. So let's recap. Covered information in a short amount of time about Section GG. My objective for today was that you were able to learn about those identified issues in Section GG and the MDS, and why potentially your SNF claims are being recoded into a different PDPM rate upon review. So we accomplished all that today by really reviewing those drivers, those things with the money bags, and those things that are marked in green on that Briggs sample that I showed you for Section GG. And we really talked about the importance of the assessment and the timing of that section. Remember, it's the information that occurred within the first 3 days. And so if you're relying on information that was done outside of that to complete that assessment, it very well may be changed upon medical review to the information that we can find within that first 3 days. And finally, we discuss why that MDS information and documentation must match. Again, those questions, you know, we did have a couple of them that came in about the interdisciplinary treatment team and what if their information is different than what else is being reported. That's an internal issue for you as a skilled nursing facility. And so it's going to require some education within your facility and within your staff on how you're going to accurately capture that and what information is going to be used to code the MDS. And if it is all over the place, there's nothing that hurts making a caveat in your documentation that says the information used to code the MDS comes from this section obtained within these dates. And that will draw a reviewer to those sections, and we know they're within that first 3 days of admission. So at this time, and I know we're a little early of our call end time, but I'm going to open it up to some questions. So Rachel, do we have any questions that have come into the chat?
We have one question. If you make changes, does MDS need to modify their assessment?
All right, so if you make changes, so I guess I need a little bit more information. If you make changes in the documentation, do you need to change your MDS? Or if you change, I'm not sure if the person that's asking the question could kind of send some clarifying information. If you make changes, does MDS need to modify their assessment? And I'm assuming that you're asking if you need to do a supplemental MDS if there has been some significant changes. And the answer to that is yes, you can do a supplemental MDS if there has been significant changes to your patient. But if that's not answering the question, I'm gonna give a few seconds to see if the questioner puts in some clarifying information. And are any of my other panelists able to weigh in on their thoughts on what the actual question may be pertaining to? Okay, not seeing anything yet. If the analyst makes changes on medical review, yes. So if the medical review analyst makes changes.
I think I understand the question.
Sure.
Yeah, so this is Linda Oliver from WPS Medical Review Department. I will let you know that if your claim undergoes a medical review and the nurse analyst decides that there is a change needed to the MDS, there is nothing on the back end that you as a provider need to do. You do not need to go back out to your MDS and make any changes or resubmit an addendum to your MDS.
Perfect. Thank you, Linda. And that's right where I was going to go to after she said the analyst. And yes, okay. So perfect. Thank you for helping with that. All right. At this time, I'm not seeing any other questions that have come in, but this is not your last opportunity for questions. So I will pause again. I'm going to move on the slide deck, and I will pause again at the end to see if any additional questions have come in. So I am going to go back and look at the chat. And I do see we have one more question that came in. Please discuss how to determine usual function when level of function varies between therapies and and the interview, observations, etc. And Cheryl, this is where your interdisciplinary team really comes into play. And it should be a discussion as a not only interdisciplinary team, but multidisciplinary team of everyone coming together to determine where you really think that your MDS coordinators or hopefully they're still called MDS coordinators, and people completing your MDS are getting the information from. So it really needs to be a discussion with all staff of how we're all collectively coming together in the first 3 days and how that information or where that information is going to be gathered from. Unfortunately, there's no good form or anything like that that you guys can use. There have been a lot of great forms that we have seen various different facilities utilize as an interdisciplinary team, and it is information that is brought over from PT, from OT, from speech language, from nursing, and they collectively write that information together, and it's a pretty accurate reflection of what they're seeing in their assessments on initial assessment in their areas as well. So we just caution you to make sure that everyone is speaking. When they're not speaking, that's when there tends to be review findings. When nursing is reporting something that's way different than therapy's reporting, then is way different than what actually ends up being on the MDS, we have to question which one's true. So we're gonna tend to look to the one that is most documented the same over and over. And sometimes it could be a lesser level for you. Sometimes it could be a higher level, but you know, unfortunately, those conversations need to happen within your facility first. So that's the only piece of advice I can give. I don't, if anyone from MR has any other advice that they could give Cheryl, could, you know, you can add that as well. Hearing nothing, I'm going to say that medical review agrees with me. So, okay. All right, so that is the last of our questions. That takes us almost to the end of time as well, end of our time together, not the end of time. So on behalf of myself and Rachel and Jennifer, as well as all of Provider Outreach and Education and our Medical Review Department, we want to thank you for your participation in today's event. Remember, there are 2 more sessions on the MDS coming up in the next 2 weeks. Next week will be on section I, and the following week will be on section O. And this concludes our webinar, and you may now disconnect.